Hi, listeners.
Hello. Welcome to the MedInsights Unleashed podcast
With your hosts,
Z.
and John. Hi, everyone, and welcome to MedInsights Unleashed. Zara and I would like to thank you for all the support that you're giving us. Talking about Zara, unfortunately, she's unable to join today's episode due to family commitments. We have a great speaker today with us, Professor Pierre Gholam from the University Hospitals in Cleveland. Pierre is a world-renowned hepatologist. He's the professor of medicine at Case Western Reserve University School of Medicine. He's also the medical director of the Liver Center of Excellence at the University Hospital. He's also a director of the hepatobiliary multidisciplinary disease team at UH Seidman Cancer Center. Pierre is following up from his first episode, From Hepatitis to Fatty Liver, Unmasking the New Faces of Liver Cancer. In this episode, we briefly discussed the role of GLP1s in the treatment of metabolic disease and liver cancer. So we asked Pierre to come back and really expand on the role of GLP1s in liver cancer and metabolic disease. So my first question to Pierre is, would you like to give the audience an overview to the role of the hepatologist in the treatment of liver disease? Over to you, Pierre.
Of course, yeah. Thanks for having me again. I appreciate it. I enjoyed the first go, and hopefully this will be informative to the audience too. So I think this is a critical time to have a better understanding of our cross-disciplinary pieces, right? Because increasingly medicine, this is not just cancer or any discipline really. All medicine has become cross-disciplinary. You do not really get the full breadth of the expertise and care that you deserve as a patient unless multiple stakeholders are involved and can actually truly weigh in on what your best care process is. And this is nowhere more true than in cancer in general and in liver cancer in particular, where, as you well know from your illustrious career developing liver cancer drugs, you need not only a medical oncology expertise, you need a surgeon, you need a radiologist, you need a hepatologist, you need a navigator, you need a survivorship person in order to optimize your outcomes. And a hepatologist, I think, is a critical piece in the care of the patient who has liver cancer and many other cancers, but biliary tract cancers being the most obvious one. A hepatologist, of course, cares for the patient's liver, is typically the person who initiates diagnostic testing that leads to a diagnosis of cancer. In some instances, perhaps not as much as we'd like to, treats the cancer. But if they're not treating it specifically themselves, very closely works with the medical oncologist or the interventional radiologist to ensure that the treatment is not only effective, but also safe and preserves the patient's liver function in a way that allows them to have a good quality of life and also to continue to receive treatment over time. So, hepatologists, of course, do many other things. We're going to talk about metabolic liver disease and how it ties into cancer next. But that's, I think, contextually how this relates to the question you asked.
Thanks very much for that. It really is a village when we're treating cancer these days. And as you said, for the best outcome from a patient perspective, they should be involved with a multidisciplinary team in their therapy. And that was one of your major points in your last episode. In that episode, we did bring up GLP1s and metabolic disease. And so we'd like to step into that discussion today, Pierre. So can you just give us an insight into the research that's going on into GLP1s in cancer therapy? And you also mentioned in that episode that there's GLP-2s and 3s now being developed as well.
Sure. Yeah, I mean, GLP-2s and 3s are probably a little bit further behind in terms of how we understand their impact on cancer. They're certainly investigational drugs, I should say, that may in turn be useful in settings like cancer chemoprevention. GLP-1, of course, is the sort of the arguably the most talked about, most discussed, most in the news drug in medicine today, right? But GLP-1 is only one of the potential targets of incretins, right? So there's GLP, there is GIP, which is another target, which is now frequently used in different treatments. Tirzepatide, an FDA-approved treatment, actually is a dual GLP-1 GIP agonist. And there are even what we call triple Gs, triple agonists, which target not only GLP-1 and GIP, but also a glucagon receptor. So they're triple G drugs. And these are very much in the works and likely to reach the patient by, I'm going to guess, circa 2028, probably is the earliest when that's going to happen. But for now, we have a very large exposure of the worldwide and specifically US patient to specifically GLP-1s. In fact, as of yesterday, you may have heard there was a Gallup poll that shows that 15% of Americans are currently on some form of an incretin, typically a GLP-1. Most of this is prescribed, but some of this is still purchased out of pocket through a compounding pharmacy. The applications of GLP-1s have expanded dramatically over the past 10 years. Initially, these were drugs that were thought to be effective for treating type 2 diabetes, and that indeed was the first indication for them. But since then, we now have 7 different FDA-approved indications for GLP-1s and dual GLP-1s GIP. I'll rattle them out. Obesity soon became the main focus of treatment for these drugs. A patient who has a BMI greater than 27, so doesn't meet the cutoff for obesity, but has a comorbidity like osteoarthritis of the knee or sleep apnea or other metabolic conditions would be a second one. Cardiovascular risk reduction in someone who has known heart disease. So if you have a stent in your heart, for example, because you've had a heart attack or you had heart disease, a GLP-1 is shown to reduce your likelihood of dying from heart disease by about 15 to 20%. No other intervention does that. This is probably even better than a statin, as shocking as that may sound. A reduction in worsening of kidney function in the setting of diabetes, obstructive sleep apnea. Tirzepatide is the only FDA-approved drug for the treatment of obstructive sleep apnea other than a CPAP machine, which people slap on their face when they have that. And more are coming, and that includes HFpEF, heart failure with preserved ejection fraction, where you're likely to reduce hospitalizations by about 30%. That is, by the way, one of the most common reasons people get admitted to the hospital, and many more, including potentially osteoarthritis of the knee, polycystic ovary syndrome, you name it. Now, cancer specifically is not currently the target of a specific clinical trial. We do not have, I'll take you back in time here, John. We don't have a STORM trial of sorafenib for adjuvant therapy after curative intent, right? We don't have that with semaglutide or tirzepatide. Maybe we will someday, and I would submit to you that we should have something like that. But we have pretty extensive evidence published based on established data sets of patients taking GLP-1s that shows a pretty remarkable cancer chemoprevention effect. The most recent iteration of this was just published in JAMA not even 2 months ago. This basically shows that in a setting of obesity in an adult who receives a GLP-1 receptor, you impact a number of cancers, including the ones known as obesity-related cancers, so ovarian, pancreas, liver, of course, very prominently, BTC, many of these. The only one that seems to not work out so well actually potentially increases the risk of is kidney cancer, something I know very little about. But for all other cancers, it appears that these, and now there's been 3 or 4 attempts, including one from the late Nate Berger here at Case, that basically shows a consistent reduction in risk of cancer over time, including these 13 obesity associated cancers.
You mentioned in the last podcast about metabolic disease and the number of patients in the United States with metabolic disease. Those numbers were astronomical. So would you like to repeat the incidence associated with this?
Sure. So we believe, based on pretty rigorous data that have been replicated in other countries and other places, that roughly 1 in 3 Americans has excess fat in the liver, which we generically used to call fatty liver disease. And then we decided we didn't like that term, and now we call it MASLD, metabolic dysfunction associated steatotic liver disease. Really rolls off the tongue very nicely. So now 110 million Americans have MASLD, fatty liver. Just call it fatty liver. And of those, about 8%, we think, have a more progressive type of fatty liver disease that may set you up for cirrhosis over your lifetime. Now, if you do the math, that is an additional 8 to 10 million people, right? An
Right.
enormous number of people. Just for scale, if you remember, hepatitis C used to be the be all and end all of hepatology. We've now largely, we're well on our way to eliminating that. But even at its peak, hepatitis C was about 3.5 million people. So we are talking about a potential for morbidity in a much larger number of patients, right? I think that's the point here. Of those patients who develop MASH, about 20% of them over their lifetime, at least, will develop cirrhosis. And of course, once you develop cirrhosis at the rate of 1 to 3% per year, you are likely to develop liver cancer. So you can see how the major pipeline for development of liver cancer in terms of etiology is already become, I would argue, fatty liver or MASLD, and its more progressive form, which we call MASH, metabolic dysfunction associated steatohepatitis.
In the last episode, you mentioned that this is one of the areas that you've been inundated with questions from patients that you're treating or patients where you're giving advice to. What sort of questions are you fielding when these patients come to you to ask about GLP1s in cancer therapy?
Yeah, so it's an interesting area because remember, the patients and the public, by extension, are inundated with information about incretins, GLP-1 agonists, right? You can hardly, click on a link or a website or watch the news. This is now daily news, right? This is not even medical news, right? Anything that happens in the GLP-1 space automatically makes it to the front page of the New York Times, for example, which reflects, I think, the public's interest in this. Now, much of this interest does not have anything to do with liver health or cancer, of course. This is driven very heavily by the obese or overweight patient's desire to lose weight. And that's an understandable thing, right? I'm not implying that there's anything wrong with it. But what happens is often in the process of seeking care for complications of metabolic dysfunction, which include liver disease, you end up stumbling on this area, either on this diagnosis or a similar diagnosis. So patients typically want to know how they can treat this, how they can potentially make it better. Can they reverse it? Can they reduce the amount of scarring? Can they reduce their cancer risk? All of these are important questions to ask. And of course, patients want to know, am I a candidate for a treatment like an incretin? Is this something I could benefit from, not only to reduce my weight, but also to reduce my risk of metabolic complications over time?
So, how does a patient come to you and be diagnosed with metabolic fatty liver? And then what's the steps involved with the treatment associated following on from that scan and the multidisciplinary team's approach to the treatment of that patient?
Sure. So in 2025, the vast majority of patients who come to see us are referred by a primary care doctor or a family practitioner, primarily because they've had some evidence that suggests that they have fat in the liver. And what is that evidence? Increasingly, it is an imaging study done for something completely different that reflects fat in the liver. Remember, as a paramedic, you would be keenly aware of this. If you show up to an emergency department anywhere in North America, it is almost impossible for you to leave that emergency department if you have a complaint between the neck and the waist without some form of imaging.
Scan. Yeah.
If I'm lying, I'm dying. This is absolutely true. You will not leave that ER until an emergency physician has laid eyes on a CT scan or an ultrasound and declared you safe to go home.
Right.
And because of this large volume of imaging that we do in this country, we uncover a lot of incidental findings, right? And one of these, because 1 in every 3 Americans has fatty liver, is bound to be fat in the liver, not surprisingly. So that, I might argue, is the greatest source of referrals. The other, of course, is elevation in liver tests, which can also suggest fat in the liver. I might caution your audience, though, that over half of the people who have MASH, the more progressive form of fatty liver disease, do not have elevated liver enzymes. So this is not something you should bank on to make a diagnosis of fatty liver, but it is certainly something that alerts the primary care physician or the family practitioner to the fact that this may be the case. So once the patient comes to our office or to a specialist's office, it is incumbent upon us to refine this diagnosis and determine whether they have a more progressive type of fatty liver, whether they have MASH, right? Or whether they have scarring in the liver called fibrosis. And we do this increasingly, and I might argue almost exclusively, with the use of non-invasive testing, which includes a test called liver stiffness measurement. There are many different proprietary manufactured devices that can do this. They are in office. You don't need to go anywhere to have them done.
Can
And
you explain that liver stiffness? What's yeah.
sure. So liver stiffness measurement. Let's kind of tell a small anecdote that might illustrate this well for the audience. So the origins of this, as with many things in life, come from a cave in France somewhere. So in France, where there is, of course, a very strong culture of cheese making, there was a time when they would mature cheese, Camembert cheese primarily. One of my favorite cheeses, a stinky cheese, which many people don't like, but I absolutely love it. They would mature it in these caves, right? And the only way you would know whether a wheel of cheese with a rind covering it is actually ready for consumption or not used to be the nose. So there would be these guys who would be working these caves for decades, and they could sniff about and know whether the cheese is ready to be cut and sold and consumed. The problem with that is if you core the cheese or cut it before it is mature, you ruin the cheese. That's a wheel of Camembert is a lot of money, right? So you don't want to do that. Eventually, someone figured out that you could actually apply an ultrasound device against that rind, and you could measure the stiffness of the cheese, and you could actually tell scientifically whether the cheese is ready for consumption or not. And legend has it that a hepatologist was taking a tour of a cheese cave and asked what they were doing. And they described to him the process, and he thought, maybe we can do the same thing to assess scarring of the liver by applying an ultrasound machine to measure stiffness of the liver. Remember, cirrhosis or stiffness of the liver is a more stiff medium through which an ultrasound wave goes through. And if folks remember Laplace's law from high school, right? The stiffer the matter, the faster the velocity of something traveling through it. And that is the principle behind what we call vibration-controlled transient elastography. This has since been refined. Boy, I went off on a really long tangent.
Yeah, you did do.
Yeah,
That's okay.
yeah, that's probably reflects my love of cheese and the liver at the same time. But anyway, but basically, this is the technique we now use to assess liver scarring without needing to do a liver biopsy. There are also blood tests that are proprietary blood tests that can do the same thing, and they do a pretty adequate job for sure. And of course, if you pair them together, even better, right? You have two
Okay.
layers of testing, which make it much more accurate.
I was going to ask you, that's great news. Is there a biomarker associated with this at all?
So there is really no pure biomarker, the elusive HCC biomarker, right?
Yeah.
Yeah. You and I have had many conversations about that. There is no one biomarker. So a lot of these blood tests, these proprietary blood tests, basically take components of scar tissue, right? Components of what makes scar tissue, like the TIMPs and many of these compounds that make scar buildup, and they correlate their levels in the blood with the amount of scar. And it is, of course, not a biomarker, right? That's kind of like
Yeah.
some sort of assessment of the physical property of the liver, if, for lack of a better description.
So what's the next step after you've associated or the liver being stiff or not stiff?
So if the patient has cirrhosis, they have F4 fibrosis with this machine, you implement a series of interventions that monitor them over their lifetime for complications of liver disease. You screen them for liver cancer with ultrasound. You test them routinely for severity of liver disease with the MELD score, right? So this is a
Yes.
score that takes components of your blood testing. You see them every 3 to 6 months to make sure they are not developing complications of liver disease, which include, as you know, ascites, varices, bleeding, cognitive impairment, which we call hepatic encephalopathy, et cetera, et cetera. So all of these are essential components of how you manage the patient. If the patient has lesser degrees of scarring, let's say the patient only has F2 fibrosis, right? So they're halfway between having no scarring and cirrhosis. There, if you have F2 or F3 fibrosis, which means the step right before you develop cirrhosis, we have made some significant advancements in actually offering these patients pharmacological therapy. We can offer them a medicine that is proven to reduce scarring in not every patient, but certainly a good number of these patients. And these now come in two flavors. I'm sure many, if we do this again in 2 years, we'll have many more names. But at this point, they include a medicine called resmetirom, which is a pill you take every day that has been shown in a randomized controlled trial to reduce inflammation and scarring. And the aforementioned semaglutide is now FDA approved in the treatment of patients who have F2 or F3 fibrosis. These treatments are not approved for cirrhosis, and they're certainly not approved for people who have lesser degrees of scar.
The liver is one of the few organs that regenerates itself, right? So can actually heal itself. In this disease where we're looking at GLP1s and early treatment, maybe F2, F3, have they made a difference in the liver actually improving?
Yes, so there is evidence that shows that in not every patient, of course,
No.
but in a substantial percentage of patients, perhaps anywhere between 20 to 30% of patients, there is improvement in scarring. There is reduction in scarring.
Wow.
Of course, these studies are only 52 to 72-week studies, so you do not know what happens if you give this drug to the patient for 3, 4, or 5 years, right? Only time will tell. You also don't know if you give the drug for longer whether there will be tachyphylaxis to the effect of the drug. Perhaps the drug doesn't work forever and ever, right? There are questions that remain unanswered for sure. But for now, these drugs are absolutely proven to reduce scarring, not in most patients, but in a substantial percentage of patients.
What's the negative side associated with it from an adverse event of on the liver or on other areas from GLP-1s versus current therapies that you've
Right.
just mentioned.
So the irony here is that both this pill, which is not a GLP-1, it's a thyroid hormone receptor beta agonist called resmetirom, and the GLP-1s, of which only semaglutide Wegovy is currently approved, they have very similar side effects. So those include nausea, they include diarrhea, and they include mostly gastrointestinal complications. Neither semaglutide nor resmetirom has been shown to have significant direct liver toxicity. With any drug, of course, you can get an immunoallergic reaction, allergy, just like you would take penicillin or anything, right? And that can certainly happen, but they are not, of course, drugs that are thought to be directly toxic to your liver, which is good because you're giving it to people who have liver disease. There is a finite discontinuation rate of these drugs for people who don't tolerate them. In the case of resmetirom, it's about 6 to 9% at 1 year. And in the case of semaglutide, depends on what study you look at, but a substantial rate of discontinuation or not being able to ramp up to the full dose. Remember, you don't start semaglutide at the maximum dose, which is 2.4 milligrams. You start at 0.25 milligrams and you ramp up 1 month at a time. So it typically takes you 5 months to get to the full dose. And that's probably someone who uses these drugs knows this very well, but it's a more involved process. Of course, it's an injection too versus the other, which is a pill. So those are differences.
They're bringing out pills, though, right?
Say again.
They're bringing out GLP-1 pills.
They are bringing out. Well, there is already a GLP-1 pill. It's called Rybelsus. It is semaglutide with a gastric stabilizer. I'm not the world's foremost expert on Rybelsus, but Rybelsus does tend to have side effects, of course, even though it has this gastric stabilizer, and it does not potentially cause the same magnitude of weight loss as the injectable GLP-1s. It doesn't appear like it. It is a very good medicine, I think, for diabetes, as best I can tell, but not so much for some of the other metabolic complications, and it hasn't been studied in fatty liver, just to be clear. But there are many other oral GLP-1s that are in the works. I mean, we could spend an hour talking about this. Let's talk about the one that's closest to actually being FDA approved, we think, and that is orforglipron. Orforglipron is an oral GLP-1 that's manufactured by Eli Lilly that is likely completing its registration trials. We have 2 papers in the New England Journal of Medicine already that show
that. Congratulations on that too, by the way.
Yeah, that basically show a very significant reduction in hemoglobin A1C and also a weight loss. And obviously, we are becoming increasingly a culture in this country that actually injects a medication. We're not scared of injecting medication as much as we were, I don't know, 10, 15, 20 years ago. But of course, scaling up medicine, it always works better if you have a pill as opposed to an auto injector pen, which is much more complicated, of course, more expensive to make, which is another scalability issue.
Will there be randomized phase 3 trials with these coming out soon?
There are for fatty liver or for?
Yeah, for both, fatty liver and cancer.
There are no plans to do orforglipron randomized trials for fatty liver, but we could. Only the Lilly folks can answer that question. There is a very large clinical trial for tirzepatide, which is an already FDA-approved drug, and a drug called retatrutide, which is the triple G, right? That one blocks GLP-1, agonizes GLP-1, GIP, and glucagon. And that trial is just about to open up and will probably not report for another 2 years. Very large trial that will probably determine whether these drugs work effectively but those are all injectables. These would not be right.
Would you use a combination of these?
Yeah, you're asking all the right questions. Yes, you're thinking like a hepatologist. Would you use a combination of
a GLP-1?
Right, a drug that works through overall improvement in metabolism and remember the other drug is liver targeted. It basically specifically works on your liver to defat it. Well, up until this point, it was difficult to do this because you had to have the assets to do this, right? As a pharmaceutical company, you'd have to have different assets. Increasingly, that is the case. All these folks have wizened up to the prospect of potentially using different mechanisms of action at the same time. So it is being done. Those studies are actually starting to be done. We don't have data yet that show definitively whether that is the better way to do it. But we have subset analyses from the study that led to the FDA approval of this drug, resmetirom, right? Which shows that in the subset of patients who actually were already on a GLP-1 agonist, this was primarily dulaglutide, liraglutide, and semaglutide. You basically did tend to see the same magnitude of response. And in fact, in people who lost more than 5% of their body weight, this drug does not make you lose weight. The resmetirom drug by itself does not make you lose weight. But in those who lost weight either through diet and exercise or through this treatment with a GLP-1, they actually derive even more benefit, which stands to reason, right? Makes sense that that would be the case. So definitely, I think to your point, that may be the way of the future. We don't know yet, but certainly something to think about.
So are you treating a lot of patients now in your own practice?
Yeah, absolutely. Yeah. So there is, I would say conservatively that 50% of all the patients I see in my practice now in a general hepatology clinic, we're not talking about the cancer part, but just in a general liver clinic are patients who have fatty liver. Now, not all of them have MASH, of course, but that translates into an absolutely enormous number of patients, right? If you think about it. So, yeah, I mean, we treat, if you're asking about whether we treat with these drugs, absolutely, that is I would say a daily occurrence, not a weekly occurrence, for sure.
Daily occurrence.
Yeah. Yep.
Well,
Not today because we're talking, but days when
this afternoon, maybe after we finish the podcast.
That's right. Yeah.
Oh, that's incredible. That's incredible. So are you seeing major benefits from your own practice? We're talking to a lot of patients now, and that must have a zillion questions. You're treating 50% of your patients are fitting into this category. So what are you seeing personally?
So definitely, so of course, the next question we should ask is, you're giving these drugs. I told you they don't work for everybody. How do I know? These are not inexpensive drugs, right? How do you know whether you should keep someone on this or not? And the answer is we now have some guidance that allows us to understand whether the patient's deriving benefit or not. So very simply, we repeat the test. Some people do it after 6 months. I'm a fan of repeating this after a year just to give it a little bit more time to act. And if your numbers actually drop, and we think a 30% drop in your vibration control transient elastography, your liver stiffness, remember the cheese test, right? If there's a more than 30% drop a year later, very good sign. That means that you probably are responding and you should probably stay on this medicine for the time being. If you have some improvement, but not within that 30% range, you're probably stable, right? You're not necessarily improving, but you're not worsening, which for someone who is on the cusp of developing cirrhosis, not a bad thing, right? You don't want to progress to cirrhosis. If your numbers are clearly worse, then you have to wonder whether the patient's benefiting, and perhaps you should pivot to a different treatment. Remember, there's 2 treatments.
Yeah.
Or put the patient in a clinical trial, or just do something completely different from what you've decided to start them on in the first.
What trials are you running, Pierre?
So in addition to incretins and this drug called resmetirom, there are other drugs in the same classes, of course. I mentioned tirzepatide.
Yeah.
There are a number of others, pemvidutide, etc. So all of these are incretins. And in addition to resmetirom, there are other thyroid hormone receptor beta agonists. There are other classes of drugs, including a class of drugs called the FGF21 agonists. There's 3 of them. All have been gobbled up by Big Pharma in the past 3 months. So literally they were owned or developed by small pharmaceutical companies. They're now owned by the likes of Roche, Novo Nordisk, and
JSK.
Yes, so those are, I think this reflects, I think, for those who follow your podcast, who maybe industry insiders, I think this would not be a trade secret to say that almost no major pharmaceutical outfit today can realistically satisfy its shareholders without having a robust incretin platform. It's almost impossible. I bet you your shareholders will revolt if you told them you don't have something in the works that address this, right?
Well, let's not talk about shareholders.
Yeah,
That's left up to those guys. So let's talk about the patient that fails, that doesn't react, the one that goes on. What are the steps that you can take to minimize the risk of liver cancer, and then ultimately what happens to them at the end of those?
right. So obviously we think, because that's what we open with, right? We think you are able to somehow mitigate cancer risk by treating the patient, right? Reducing the amount of scarring. And we don't have definitive proof, in fairness, that that is indeed the case, but we think so. But then you can, why does a patient come to see you? They come to see you because you counsel them on diet and exercise. You talk to them about interventions that may be able to reduce their lifetime risk of developing cancer. And these include staying away from things that increase your risk, alcohol, for example. So maybe we should have a third podcast just on alcohol. But our philosophy in how we interface with our patients has changed quite a bit. We used to have a more permissive attitude towards alcohol consumption. Increasingly, we take a much more, I don't want to call it stern, but more evidence-based approach. As you know, the WHO 3 years ago announced I don't know about much fanfare, but announced very clearly that the evidence suggests that there is no safe level of alcohol consumption. In other words, no human
Wow.
being should be advised to consume alcohol on the guise that this in some way, shape, or form can be managed or has some health benefit. The Institute of Medicine produced a 230-page report 2 years ago, which the Surgeon General, our last Surgeon General, took to heart and announced the same thing, that there is really no safe level of alcohol consumption. And increasingly, we in the profession in hepatology, I think, stick to that same refrain, right? We tell our patients, especially if they have liver disease, right? Particularly if they have liver disease, that they really should not be consuming alcohol. We say this, of course, in a non-judgmental and supportive way, right? And we're certainly going to stick with our patients whether they decide to continue to drink or not. But we would not in any way give them the illusion that consuming alcohol to any extent is beneficial to their health, right? Which is to some extent what we used to do in the past.
And you've mentioned that alcohol, but what else is there in the prevention side of things?
Other than alcohol, well, there's certainly diet and exercise. Reducing your weight seems to be associated with a reduced risk of not only liver cancer, but all cause cancers. There are no pharmacological interventions. One wishes there were any pharmacological interventions that clearly reduce cancer risk at this point. Of course, the story of this. You got your vitamin K2. You got all these trials, that massive trials that were done that basically look at populations at risk and whether you can reduce the risk of cancer. And that just has not panned out yet. I am, again, one more time, optimistic that if one were to run a cancer chemoprevention trial with an incretin, that probably would pan out, but that's just my own personal opinion.
And you did mention you had another topic on your head that you just said one of the areas that we should talk about.
Right. So one of the other things that we should mention is that we now finally, after knowing about this for all our careers really, have decided that there are, shockingly, people who are obese, have metabolic dysfunction, and, oh, by the way, drink a lot of alcohol, right? We call these folks MetALD. That's a new term that perhaps folks in other disciplines may not be familiar with. MetALD stands for metabolic dysfunction associated alcohol associated liver disease. So basically means that you have a double whammy, right? You have diabetes, you're obese, you perhaps have very bad metabolic function in general, and you consume a significant amount of alcohol, which we've defined somewhat arbitrarily as more than 21 beverages per week for males and more than 14 for females. I would venture to say that even that probably can set you up for Met ALD. And Met ALD, we now know, is actually worse than just having one thing or the other. There's some evidence that perhaps alcohol-associated liver disease in its purest sense may be worse, but it's certainly worse than just having fatty liver disease by itself. It adds morbidity to that.
And what's the treatment for a Met patient?
That's the great question. Those are coming. So we do not have FDA-approved treatments for this new, well, not so new, but just newly highlighted, I would say, newly highlighted Met ALD. We're finally thinking about doing clinical trials to treat Met ALD.
So what percentage of the population would be a Met ALD?
Nobody really knows, but what percentage of Americans have an alcohol use disorder? We know that very well, 10%. 10% of Americans have an alcohol use disorder, meet criteria for alcohol use disorder. 28 to 31% of Americans have fatty liver, more people. And so Venn diagrams, right? If you kind of think about intersection of both, you have a substantial number of Americans who have Met ALD, for sure.
For those people that are overseas, different races that are here in the United States listening to this podcast, is the treatment any different? Is there different categories for different ethnicities associated with Met ALD, MASH, NAFLD?
So in the EU, finally about 3 months ago, resmetirom was approved by the EU for the treatment of MASH with F2 or F3 fibrosis. That, I believe, is the only other place around the world where that drug is accessible. Maybe Japan, but I'm not sure. I don't think Japan. For other places, there aren't a whole lot of pharmacological interventions that are FDA approved. In India, there is an Indian manufactured PPAR, which is actually approved for fatty liver. Only in India. It's not approved in any other countries. But perhaps more importantly, I would say that, I did a couple of trips to Asia really opened my eyes recently. We are always under the impression that perhaps North Americans, because of the obesity epidemic, would have a lot more fatty liver and MASH and MASLD, right? Not so much the case. This is a worldwide epidemic. For example, South America, where there's also a very strong genetic predisposition to fatty liver, probably has a higher prevalence of MASH than the US. The Middle East area, the MENA area, has an incredibly high prevalence of MASH. And probably the largest area of growth of obesity and MASH is actually not in the US. It's in the Indian subcontinent, where you have an epidemic of obesity in children, which is apparently driving the MASH epidemic there. So this is really not a North America or a Western European phenomenon. This is a worldwide phenomenon.
Question, you just brought up an interesting thing. You said they have a genetic disposition to the disease. Does that genetic disposition actually just impact regardless of the way they look after themselves? If there's a family history and they're trying to really look after their livers,
right,
are they still at risk? Is there a chance that they would get it regardless of what they do?
So there are definitely single point mutations, and so I should step back. I'm not trying to imply by any means that MASH and fatty liver is a monogenic condition, right? You have one gene and that gene sets you up for fatty liver. That is not what I'm trying to say. But there are clearly at least 3 genes we have identified, the most important of which by far is this PNPLA3 mutation, which actually very significantly sets you up for an increased risk of having the more progressive form of MASH. They also ironically increase your risk of cancer if you have MASH. So that is much higher in prevalence in Latinos than in anybody else. Specifically, Mexican Americans have a pretty high prevalence of PNPLA3. There are two other genes that we also know. These, by the way, can be commercially tested for. Unfortunately, insurance doesn't pay for them very often. One of them is called TM6SF2, and the third is called HSD17B13. That doesn't matter what the names specifically are. But those three genes clearly, in a population studies, increase your risk of MASH. I guess your question to some extent is, do we often test people who have a family history for these? The answer is that is the road less traveled, and perhaps we should do this more often. The problem, of course, is insurance does not pay for these genetic tests. So it is difficult to offer that to a patient when they would not be able to get the test paid for. And of course, the other part of this that's important is most people who have a genetic clustering, a clustering of fatty liver don't have it because of a genetic component. They probably have it because of a shared environmental component, what they eat, their exercise habits, et cetera, et cetera. So just to make this pretty clear.
Well, Pierre, you've covered a lot in this topic today. It's been an amazing discussion. How would you summarize this talk on GLP1s in liver cancer and the role of metabolic disease in a summary format of 3 to 4 bullets, just to close out?
Sure. So I think that metabolic dysfunction is a sort of an overarching theme that now permeates almost every medical specialty, not only hepatology and gastroenterology, but also medical oncology, you name it. So I think it behooves all of us to educate ourselves more about this and stay up to date on where this is going. The second point I'd make is that there is pretty good evidence, in addition to all the established indications for incretins, that these may be cancer chemopreventive drugs. And more on that, I think, will come in the next few years, but certainly something we should be paying attention to. The third point I'd make is that there is a biological plausibility for why these drugs may actually impact cancer and liver disease. Of course, they reduce many of the underpinnings of why you get fat in the liver and why you get scarring in the liver. We didn't even talk about their anti-inflammatory effects, which are obviously very important. This is not just, guilt by association, right? There's clearly a reason why this is the case. And I think last but not least, we're going to have an explosion of these drugs, both in terms of numbers and in terms of Americans who are on them. So I guess I can close on this. There are a number of estimates that up to 35 to 40% of Americans will be on an incretin by 2035. So this will become certainly a staple of medical care, not something that you should, categorize as a niche treatment of any kind.
Yeah, you did mention inflammation, which is a big issue. Maybe you can add that in as a fifth.
Yeah, sure. I mean, so these are anti-inflammatory drugs, which is why they seem to work in conditions that are not exclusively driven by weight loss. So osteoarthritis of the knee, many of the other systemic problems like obstructive sleep apnea, et cetera. Well, that's certainly probably a big part of why they work in cancer, because they reduce inflammation, and inflammation is a big driver of cancer in general. So.
Well, Pierre, I've got to thank you on behalf of MedInsights Unleashed and also all our listeners out there for this talk today. It was very interesting and answers a lot of questions about GLP1s in cancer. And we look forward to having you on again on MedInsights Unleashed. Be well, mate. MedInsights Unleashed disclaimers. This podcast is for general information purposes only and should not be considered healthcare advice in any way. The podcast is not intended to replace professional medical advice. The use of the information and material linked to the podcast is at the user's own risk. MedInsights Unleashed is not responsible for any losses, damages, or liabilities that may arise from the use of the podcast. Importantly, please consult your healthcare provider for individualized guidance and treatment. Thank you, and we look forward to you being with us on the next MedInsights Unleashed podcast.